We'll be talking about the generic case. The COVID has prevented you from seeing a lot of cases. And usually what happens is you see a lot of cases and some cases jump out. You see a lot of similar cases and then they give you some kind of insight and then they help you become better doctors or become better carers of people who are very sick and especially people who are about to die. Now, unfortunately, those cases are limited. So what we'll do right now is I'm going to tell you a very common scenario, but I'll give you the worst case outcome of the scenario just to derive the point. Now, after the story, I suggest you sit down and try to apply the insights that you've gotten from this in the way you take care of your sick patients. And hopefully, it doesn't end up in a very bad outcome like this particular stories. So the generic story involves a person is always in the room with the dying patient. So we're dealing with the situation where everybody knows, even the family member, they probably got told, or even if they don't get told, it's so obvious. And the way the nurses and doctors are behaving, the way they're doing less, and even the fact that they're asking about CPR and ventilators kind of tells the mom of the dying child, or the parent of the dying child, or the spouse of the dying patient, the time is very, very near. At this point, the denial aspect doesn't really work too well anymore. And it's just a matter of hours or 1 to 2 days and then they'll be dead. What happens is the doctors come in or the nurse assigned to do it. Usually it's a care manager, but ultimately it would be the doctor to verify things. In less resourced countries, you can't salary all sorts of psychosocial person to do the advanced directives, but that's what they were trying to do. They were trying to ask the grieving parent of the dying kid. They're already grieving. I mean, you grieve even before the death. The grieving parent, or do you want us to do CPR and the heart stops, or if the patient's not yet on a ventilator, do you want to intubate and put on a ventilator, and so on. And they keep on doing this. At first, it's not very regular, but when everybody realize that it is so near, they'll keep on asking the decision maker or the next of kin until the time they say, no, don't do it. This is a very difficult question, especially if you consider what's really happening. So what's really happening is you're trying to get a decision from the next of kin. Now, if you're in a country which has a law which says, if the patient has expressed his or her values, if this was not a kid and the patient doesn't want DNR, DNI, then it's pretty much the end of the story. You should respect the decision, which is documented on video or usually it's on paper. And you should respect it. That's a binding, legally binding situation, not unless the family and or the spouse of this dying patient has sufficient reason to question the validity of the decision. They feel like the patient was very distressed or the patient really doesn't realize what the real situation is. Because, every time you decide on something that's going to happen like 1 or 2 weeks later, the information that you don't have is what's really happening during that time, right? So that's one of the main arguments presented in the early 20th century when they were deciding whether it's a good thing to come up with legally binding advance directives. And they're saying, they decide 2 weeks before, they lose consciousness. And, even if they're that smart and they're not even medical professionals, even if they are, they have no idea what the situation really is. 2 weeks later, that was the against camp. Of course, the camp one would be the pro-advanced directives camp in the developed countries. So now the question is, if the patient didn't decide, or in countries where the advanced directive is not legally binding, then who should decide? In developing countries, some of those countries, especially where the religious value system is still prevalent and there's this higher valuation of human life and higher concern about misusing certain procedures that would ultimately degrade the value or the sanctity of life. You don't have those laws. So who will decide? Well, the decision would be the next of kin, the person closest to the patient. So why did they choose the next of kin? Because of all the people in the entire planet, the parent of the child or the spouse of the dying patient would most likely not decide based on their own interests, based on any other interests except the interest of the patient. They're the ones closest to the patient, and presumably, usually they're the ones who cares for and loves the patient the most. So whatever the decision is in their mind, they think it's for the best. They're not going to decide on something that they don't think is beneficial for the patient. Now, why did they take that decision away from the doctor? Because no matter how smart the doctor is, by mid-20th century, people realized there's conflicted interests, and in many cases, doctors really cannot decide well for the patient. Medical knowledge of the patient's situation is not enough. And in certain situations, even if you know all the medical information, even if you know the latest science, it's not enough for you to decide either way, because either way is valid. So they went for the next of kin. Now, there's one problem with this next of kin. They're also the person most affected by the impending death because they're closest to the patient, right? And that's the reason why you're asking them what should be done, because they probably decide the right thing. Now, of course, the other reason is the value system of the patient. They probably know about the patient's beliefs and value systems much more than all the nurses and doctors inside the hospital. Now, for the child, the theoretical argument is the maturing value system, which is not yet matured, as far as the teenager or the small child is concerned, is probably very, very similar to the parent. I mean, some people actually propose that, but of course, the most glaring argument is they probably won't decide ill. They don't have any ill intentions, and they probably won't think of decisions that would cause any harm to the dying person. They're the most affected. So when you do rounds, you'll see the parent probably not sleeping. So it's what happens when the time is very near. I mean, you cannot have the denial anymore. Usually when you still have the denial going, they look like they're okay, and they might even have decided an advance directive, but then some of them would, change it later on at the moment of death. It's very common to see the mom saying, do everything to save my child. And then doctors or nurses are saying, remember 2 weeks ago you told us, you don't want the child to suffer. And I agree with you. Don't do the CPR and the electric shock or the ventilator. And you look so calm. How come you're not calm right now? And they change, do everything. I'm changing my decision, do everything. So that's very common. So the closer the emotional attachment, the more likely you'll encounter those things. If you have a loving couple talking to each other, and then suddenly the dying patient loses consciousness, and the husband or the wife who's at the bedside knows that he or she, or the dying patient, is about to go, and it's not going to be sleeping, so he's going to be there, lacking sleep, don't want to leave the bed. The denial doesn't work anymore. So what's happening? Well, the most common answer, if you ask all the doctors, even your smartest consultants, we don't know. They don't teach that in med school. You can open up all the books of all fields, even probably your small, handy little end-of-life care manuals probably won't say it, or it probably would mention it in like 2 or 3 sentences. It's very human, and it would be very helpful for you to have an idea what's happening during those final hours. And I can tell you what's happening during those final hours. The literature is not easily found in the medical or the nursing literature, even in psychiatry literatures. And although, if you look hard enough, you might find it. You'll find it in some of the literature of psychology, but not all. I probably won't even mess around with this near-death kind of situation. Because it's so hard. And that's really not what therapists and counselors do. Usually they take care of people who are not about to die, and they have problems at home, they're depressed, or they're anxious, or they have panic disorders, those kinds of things. Every now and then they have more severe psychological problems to deal with, but not this last few hours of life. 1 to 2 out of 10, you'll see things said about this. Usually it's in the form of narratives or descriptive work, because these are existential issues. So you'll see it in psychologies dealing with death, dying, meaning, and loss and grief. You also see a lot of it in grief and bereavement literature. Actually, that's where you should look first. I'll tell you the most obvious thing that happens. I mean, you can actually even guess it, but nobody tells you, and nobody wants to think about it. It's just there in the back of your mind. How would you feel? Let's do a practice in empathy, understanding, and compassion. If you were the parent and your kid or child is there gasping for breath, and everybody knows what that means. Even the doctors are telling you, they keep on validating or asking you about the CPR, and you know that your child is about to die in the next 6 hours, in the next 12 hours. What's happening to you? If you're this loving wife or husband and your spouse is about to die in the next 24 or 36 hours, what's happening to you? Well, I can tell you, a lot of times, your focus and your emotions shifts to your situation. Your child looks comfortable, barely moving, not in distress, but about to die. Or your husband looks comfortable, but about to die. So your focus shifts to yourself. And I can tell you, based on the many narratives about the situation or descriptions about the situation, this is what's going to happen inside your head. You might even verbalize it every now and then to yourself. The mom will say, "This is it. After this, I won't be with her anymore. She's going to be dead, and I won't see her anymore. I won't see her anymore. She's going to die, and I won't be with her anymore. This is it. It's going to happen. It's happening right now. It's happening right now. I won't be with her anymore." The spouse will say the same thing. "My husband won't be with me anymore. This is it. After this, it's just me. I won't be with her. I won't see her. And this is it. We've talked about this, but this is really happening. And after this, he'll be gone. He'll be gone. He'll be gone. I'll be all alone. I won't see him anymore. Or I won't see my wife anymore. She'll be gone." And just keeps on repeating. You're at the bedside. You're looking at your child. You're looking at your spouses. And repeating. Okay, so now, let me tell you the worst case scenario. What if the next of kin is so distressed they can't make a decision? The decision is, do you want us not to attempt to revive or resuscitate your loved one? That's really what a DNR question is, right? You're feeling this much even before, you probably can't decide, right? And the problem is, in certain institutions, especially where empathy and understanding and compassion is down, that's all they ask you about. In so many words, he or she is dying. We can do this, pump the heart and ventilate, but do you really want to do that? You want to prolong the suffering? If you're a good parent or a caring spouse, you probably should sign or allow us not to do anything. Of course, if you really think about it, why do they need to sign? If it's such a good thing, that just do it on everyone. Make the doctors decide on the matter. It doesn't make sense, right? The reason why it was the next of kin is because of that very problem. There's a concern about the motives or the interests of the care providers, especially nowadays. And the motives sometimes are not very good, and they're even very glaring. If you ask them, the doctors, the nurses cannot cannot write the order DNR. It's the doctors who have to validate and to ask it in person. If you ask them, they'll say, "Well, that's the way it is." Well, why are you asking? If you just ask them point blank, they'll say, not to prolong the life, not to cause so much suffering to the patient. But you're looking at the patient's like comfortable. So what's the real deal? The real deal is, once that DNR DNI is signed, there are certain things that happen. If the patient is in a resource-intensive area of the hospital and the bills are piling up, then you get to move the patient out of that. And, it works on the finances of the institution. You get to put somebody in. As far as the hospital and staff are concerned, you don't need to keep on monitoring the patient and doing all these drips, knowing that the patient is going to die, and, you're not supposed to be aggressive anymore. We feel like once that DNR DNI is signed, even if it's not really clearly written that you have to be conservative and everything else, actually that can be legally questioned if they did that. So remember, the order just says, if the heart stops, you don't revive. That's all. It doesn't say anything about you don't be aggressive with this or that. That's a whole slew of other care preferences that you need to ask directly. But anyway, so they want us to be conservative, so we don't need to be too worried about missing anything. And you know how a code is. Everybody gets panicky. They bring in the card and they do all these things. That's not going to happen anymore. If you're the doctor, you can sleep well at night because you're not waiting for a call and you have to make a rapid decision to try to do something to resuscitate the patient or extend the patient's life. Those things are not happening, right? Glaring example of wrong interests. I mean, that's not supposed to be the reason why you want it. You shouldn't be badgering or traumatizing the next of kin because that's really what you want. Okay. Of course, a more psychological thing would be you want the family to say enough is enough, and then they've accepted it, and then you have the right not to feel too guilty because it's so difficult to just keep on going there knowing that the patient's going to die. You might extend the patient's life a little bit, but it's a clearing proof that you've actually failed to keep your promise of curing this person. You weren't able to keep your promise well. Some doctors, especially, the ones who are enterprising enough to promise everything. In some countries, doctors actually try all sorts of things to get patients, especially here in the metropolitan area where there's a whole bunch of people in, trying to grab at patients, which is a terrible thing to see. All sorts of illegal and unethical things happen because of that. That's not the topic right now. So what's happening? You just keep on asking this person. This person keeps on thinking, she's about to go, he's about to die, and I wouldn't be with my child anymore. This is it. It just keeps on happening in their mind. It's going to happen in the next 6 hours. And here the doctor just goes, have you thought about it? Maybe you should sign it. More than likely, you can't even hear it. Now, if you do hear it, constant, irritating thing that doesn't make sense as far as your mindset is concerned. What in the world are you talking about? Right? Don't you see what's happening to my child? Don't you see what state I'm in? And here you are, you just keep on asking the same thing over and over and nothing more, right? That's the problem. The worst case scenarios, I've seen cases where just the next of kin just gets out of the room. I mean, there are even cases that they just disappear from the hospital premises and they cannot find the mom. They cannot find the grieving spouse. And then the patient dies, and then suddenly the parent appears, holds her child, and starts crying. Or the loving, grieving husband appears and embraces the dead body of their spouse and starts grieving and crying. And looking at them, they really wanted to be with their loved one during their final hours. And they weren't there. Why? Because during the time they were there, they kept on getting bombarded with, just decide, tell us you don't want us to attempt to extend the life of your child anymore. They just kept on shoving that piece of paper at them. And I don't think that's the most important thing you should be doing. Especially since everybody knows that even if you attempt it, it probably is not going to work. And this thing about causing suffering, well, the patient is so far gone, they probably won't feel much of what you're doing, right? And if you're so concerned about that, you can even give something so that they don't feel much of what you're doing if you're attempting a resuscitation. They probably won't feel much of what you're doing. So what you actually just caused is you just traumatized severely the loved one. That's what you just did by doing such a thing, right? First of all, you're supposed to be caring for the loved one or the family member or the next of kin, as well as the patient. Well, obviously the patient's just comfortable waiting for death, but you should be caring for the next of kin, right? Or the family member. Well, you might say, that wasn't my job. I'm the doctor of the dying patient. But, you're also a human being. And in the mind of this grieving parent and family member, you're on their side. And you're a human being. So, the worst thing you can do is traumatize this next of kin, right? You gave this family member a very severe traumatic experience that they'll never ever forget. probably will cause a lot of psychosocial and psycho-emotional or psychological problems later on in their life. And you caused it. How can you not care, right? You're supposed to care. You're not just there to do curative stuff. You're there to take care of them, no matter what, right? And you cannot take care of anyone if you're not prepared to understand them better as people, and not just people carrying some disease or family members of the person who carries some disease, and you're the expert of the disease. You're not an expert of the disease. You're supposed to take care of the person with the disease and the family members and the loved ones of that person. That's what you're supposed to do. And then you have the right to call yourselves doctors. That's the only time you can call yourselves doctors or nurses or such. Otherwise, you're just technicians. Or if you're selling medications and prescription, you're no different from a car salesman. You're carers, health care workers, carers. You're not disease curers. So again, understanding, empathy, which leads to compassionate action. All these human beings will do that. You don't even need to have a degree to know that that's the right thing to do. Even if in your mind you're saying, well, I'm trying to protect the patient's best interest, I'm trying to prevent suffering, or the patient actually wants this, and I'm just trying to make the family member agree to what the patient wants. Well, first of all, they argued about that, and they realized there's just too much stuff that would cloud the doctor's judgment. There's just too much unwanted interests, institutional, personal, professional, as far as the people in the hospital are concerned. And even if there's none, still the best person, or the person who knows the patient so well, the person who has that kind of deep caring and love and concern for the patient, would be the person closest to the patient. Who would that be? The parent of the dying child, or the caring and loving spouse of the dying patient. It's an old argument, and it doesn't carry water. Now, that kind of argument still is rampant in many places, because, that's how we're trained. We're superior, we can cure them, and this time, we can even decide for them. So you shouldn't think that way. That's not what autonomy and self-determination is all about, right? And if you say that, just sit down and try to ask yourself if you have any other interests driving your decision to keep on bugging the next of kin to sign that piece of paper. Do you have any other interests that you're trying not to admit to? Sometimes it's so obvious, like you see this same doctor, if it was a private hospital, and this fairly well-resourced, rich family can afford an extended stay in the highly resource-intensive unit of the hospital that can keep their loved one alive for a very long time. And of course, if the person is in that unit, you also get paid more, right? So there's less motivated attempt to keep on asking them, you want us to revive the patient, and you want us to do this and that. Of course, that doesn't happen all the time. But if you see that, and then you see the same doctor go to a more charitable institution where people cannot afford those things and cannot afford to pay for them anymore, maybe that's like piling up, then there's more motivation to say, just let it go and just sign the paper and be done with it. But of course, they won't say that. They'll say, you want to prolong the suffering. The patient probably doesn't want that. You should do the right thing. We think we know what the right thing is, and you should please sign this paper, and you keep on doing that. And so the other point is, every now and then you should just sit down, especially with these kinds of emotionally and of course legally charged situations. You should probably just sit down and think about your values and your vested interests. Sometimes those things, we don't even know we have those things. Sometimes, we try to deny them, or we try not to think about them. If you want to be really true, honest, sincere, empathizing, compassionate carers, maybe you should every now and then do that. Make sure that there's nothing that's clouding your judgments. Imagine this patient was hovering around, patients already like comatose, hovering around the room, watching you traumatize their loved one. This teenagers hovering around the room, watching you constantly 3-4 times a day, past 3 days until death, causing emotional harm, traumatizing his or her mom, or traumatizing her husband. What would that patient say? Well, probably what that patient will say, watching what's happening, is, if I knew that it will end up with this 2 or 3 weeks ago when we started talking about do not resuscitate, I would have gotten up and told you to get out of the room. Or if they're really mad, who wouldn't be mad if you were seeing your loved one being traumatized by the hospital personnel? Do you know that people close to death, the future of their loved ones is more of a concern than dying comfortably? They care more about their loved ones than themselves during the final hours. And now they're looking at you. Let's say they're looking at you from above, seeing how you badger and traumatize their loved ones. What would they say? If they're really angry, they'll probably even say, if I knew that that's what you're going to do 2 to 3 weeks ago when I was still fairly strong and alert, I would have just told you to get the hell out of the room. Or I would have just gotten that document or paper you're making a sign, crumpled it, and shoved it down your throat, right? So if you're really angry, but hopefully it doesn't end up that way. But again, hopefully this story, which is based on things that actually happen, will give you insights and motivate you to become better caregivers, doctors, nurses, medical care providers. Again, ultimately, it's all about being a human person who's concerned about the suffering and dying person and the next person who's suffering the most, the next of kin. Understanding, empathizing, and being moved by compassion to act and approach them in a very decent, humane, righteous, and good manner. And that would make you a better care provider.